Bom dia a todos novamente. Eu sou Igor Morveck, médico oncologista no Hospital Sírio-Libanês em Brasília. Eu tenho aqui ao meu lado meu amigo especialista, Dr. André Sasse, diretor do Grupo Sonho de Oncologia em Campinas. We have a pleasure to be here today. Dr. Petros Grivas. Dr. Petros Grivas will discuss some important abstracts in urothelial cancer. He is a medical oncology from Seattle Cancer Center, and he is an associate professor from University of Washington as well, and clinical director of the GU program in the same university. So welcome, Dr. Petros. Thank you for your participation today.
Bom dia. Thank you. Obrigado. Thank you so much for having me, and it's a pleasure and honor to be with you today, and hopefully we'll see you in person again soon.
Thank you. Nós vamos começar então essa discussão. A discussão vai ser feita inicialmente pelo Dr. André Sasse, que vai então pontuar 2 abstracts que nós selecionamos, né? E na sequência, o Dr. Petros Grivas vai entrar para discutir esses abstracts. Então depois eu vou terminar com novas discussões com outros 2 abstracts. André, por favor.
Perfeito. Obrigado, Igor. Great, Petros. I will present my points in Portuguese, but you can see the slide in English, so we can discuss later.
Sounds great.
Thank you for sharing with us your thoughts. Bom, a gente selecionou 4 estudos, eu vou apresentar 2, depois o Igor fala 2, a gente vai separar essas discussões até para dar mais tempo, mesmo para a discussão de cada um. Os 2 primeiros estudos, deixa eu botar na tela isso. A gente vai discutir sobre tumores uroteliais e 2 estudos que foram considerados importantes pela seleção, até pela organização da ASCO-GU. E eu confesso que eu fiquei bastante desapontado com as expectativas que eu tinha para esse congresso presencial. Obviamente foi muito bom estar com todos presencialmente, foi bom assistir as apresentações, porém a qualidade ou a qualidade da evidência, não obviamente os estudos são bem conduzidos e tudo, mas a qualidade da evidência final e aplicabilidade para os nossos pacientes eu achei bastante questionável. Mas enfim, a gente tira algumas informações e isso que a gente vai apresentar. O primeiro é do estudo Trophy U01, que é uma das cortes de um estudo maior, a corte 3, que é o estudo que avaliou sacituzumab govitecan em combinação com pembrolizumab em pacientes com câncer uroterial metastático que progrediram após cisplatina. Então, os 2 estudos que eu vou apresentar aqui, os 2 são anticorpos conjugados um antineoplásico, e esse sacituzumab especificamente é um anticorpo que tem um alvo no TROP2, ele foi bem estudado já em câncer de mama, triplo negativo, e ele tem uma ação quimioterápica também importante, que tem o seu payload anexado, né? Que ele é mais potente do que irinotecano, e isso leva a uma toxicidade específica do anticorpo associada à própria quimioterapia. Então, como eu falei, esse é um estudo um estudo de fase 2 de várias cortes, e aí, os dados apresentados foram de uma corte específica, que no desenho eram planejados até 61 pacientes com câncer urotelial metastático que tinham progredido. Outras cortes selecionavam pacientes em situações específicas diferentes e vão ser apresentados ou foram apresentados em momentos também diferentes. Mas 61 pacientes foram selecionados para tratamento em combinação com sacituzumab govitecan e pembrolizumab, e o desfecho primário, o endpoint primário, seria sobrevida, taxa de resposta global, e os secundários seriam sobrevida global, livre de progressão e tolerância. Uma questão específica foi que, primeiro, foi avaliado em fase 1 a dose alvo do SG, da droga em estudo, e 41 pacientes foram incluídos nesse estudo para avaliação dessa resposta final. Nesse estudo também, fase 2, com um número pequeno de pacientes, a hipótese para definir que o estudo seria positivo era de que 13 respostas ou mais fossem observadas dentro desse N pequeno. Se não tivessem 13 respostas, o estudo seria negativo. E o que se viu de resposta foi que 14 pacientes responderam. Então, apesar do estudo pequeno, eu queria trazer essa questão, até a estatística, levantar a discussão como um todo, porque a taxa de resposta esperada para um estudo de segunda linha pequeno é discutível. Qual é o benefício que a gente espera? Qual é o desenho ideal de estudo? E o que a gente consideraria realmente um estudo ou uma estratégia de tratamento que mudaria a perspectiva dos nossos pacientes? Então, 34% de taxa de resposta objetiva foi o resultado encontrado. Uma resposta completa foi obtida, o restante respostas parciais. Porém, a gente viu num global 63 pacientes com alguma taxa de regressão da doença, com algum grau de encolhimento do tumor, se a gente for colocar assim. Então, um pequeno número de progressões. Isso, para mim, me chamou muito mais atenção do que a taxa de resposta objetiva, mas lembre que é uma combinação de pembrolizumab com sacituzumab govitecan. E eu acho que a gente precisa colocar em contexto com outros estudos que já foram feitos em segunda linha, em pacientes selecionados após falha de platina, e esse é um grande ponto. Chamo atenção aqui para a questão de toxicidades associadas ao tratamento. Então, tipicamente vistos como com quimioterapia até convencional, vamos colocar assim. Então, diarreia, náusea, vômito, neutropenia, anemia, leucopenia, fadiga, astenia e alopécia. Então, assim, acontecem toxicidades e a gente não é porque é um anticorpo conjugado à droga que a gente espera alguma coisa muito diferente. Uma das discussões que eu gostaria que o Dr. Petros alinhasse com a gente e colocasse as expectativas também é a questão de colocar em contexto esses resultados em frente às outras opções de tratamentos para pacientes com falha da platina, de esquemas baseados em platina. Qual é o valor real de um estudo positivo fase 2 pequeno? Qual que é o significado de uma taxa de resposta alta, além do esperado na nossa prática clínica, nossa tomada de decisão? E, especialmente, a questão de toxicidade esperada e qualidade de vida. A gente também viu que toxicidades com pembrolizumab não foram tão relevantes no estudo, isso pode ser discutido, mas é uma questão muito importante. O segundo estudo que entra na discussão e o desenho talvez não é na mesma situação clínica, mas é um desenho também até parecido pelo tamanho, pelo impacto clínico, e também é um anticorpo conjugado à droga, só que esse é um antinectina 4, que é o enfortumab vedotina, que foi estudado em monoterapia, não foi associado, dessa vez foi monoterapia, em pacientes com câncer de bexiga músculo invasivo, mas que eram inelegíveis à cisplatina. Também é uma corte única, uma apresentação de uma corte específica de um estudo maior, fase 2, esse estudo também selecionou uma situação clínica muito específica com um número até pequeno de pacientes. Então, pacientes que eram inelegíveis à cisplatina, com T2 até T4A N0, sem nenhum caso de tumor uroterial alto, então era câncer de bexiga mesmo, e receberam 3 ciclos de EV neoadjuvante, e depois seguido de cistectomia radical. Esse estudo me chamou a atenção pela seleção de pacientes, grande maioria dos pacientes com ECOG 0, apesar do critério de inclusão ser 0 a 2, e eu esperava pacientes inelegíveis à cisplatina como provavelmente sendo mais debilitados, e não eram, porque a grande parte dos pacientes que foram inelegíveis à cisplatina era por causa do clearance de creatinina entre 30 e 60, mas uma boa parte, quase metade dos pacientes foram incluídos somente por perda auditiva. Então isso acaba não sendo a nossa classificação clássica de inelegível à platina quando a gente olha no consultório e olha para o paciente para definir isso. Então, acho que isso é importante, especialmente por conta da toxicidade. A taxa de resposta patológica completa foi significativa. 8 pacientes, no total de 22 selecionados nessa corte, tiveram uma resposta patológica completa, então 36%, e um downstaging foi obtido em 50% dos pacientes, 11 dos 22. Mas lembrem que eram pacientes, não foi incluído nenhum paciente com linfonodo positivo, e eram pacientes com T2 até T4. De uma maneira geral, a toxicidade também foi grande, significativamente alta para os pacientes. Então, fadiga, alopecia, disgiosia, diarreia, náusea, típicos de quimioterapia. 3 mortes aconteceram, 2 associadas ao procedimento cirúrgico, a cistectomia radical, e uma insuficiência renal aguda. A discussão, e aí eu já abro as duas, é muito parecida, né? A seleção de pacientes não elegíveis à platina para quimioterapia, para tratamento neoadjuvante, eu acho que ainda é um desafio, porque é uma população muito heterogênea. E, de novo, como na outra, qual que é o valor real de um estudo positivo, pequeno, fase 2? Qual é o significado de uma taxa de resposta alta na clínica prática, na prática clínica? E se a qualidade de vida e toxicidade importam nesse momento também na neoadjuvância, quando a gente está buscando a cura. So, Petros, hi again. My worries about these studies were basically because of the size of the courts, the small number of patients included, the benefits that we don't know if they are real benefits, provide real value for our patients, and how can we put this in our clinical practice or in our minds to plan some strategy for our patients?
Thank you so much. Obrigado. These are great questions. I agree with you totally. Both of those studies, I would say, are very important, but are not practice changing, are not influencing our practice today. I think the value of those studies are to support further trials evaluating these antibody drug conjugates in advanced or localized urothelial cancer. For example, I will start with the Trophy U01 cohort 3, as you mentioned, in the setting of platinum refractory disease, and especially patients with low response rates to prior platinum and very short time between the end of platinum chemotherapy and progression. So very difficult to treat population. These are the patients who have trouble, right, how to treat. The response rate was 34%, and about 2/3 of the patients had reduction in tumor size. So very encouraging. The toxicity profile was, as you said, notable, but manageable, and the combination was feasible. However, this is a single-arm study with 41 patients and cannot influence our practice yet. But in my mind, because of the patient population, it makes me think that the combination needs further investigation. The question is where you go next. Where do you go as your next step? Do you do a randomized phase 2 trial in the second-line setting, like the cohort 3? Do you go a step earlier? Do you go to the first-line setting and you do a study there? Do you think that the response rate you get is enough or not? And we have discussions right now with the company and other investigators about it. Similarly, in the data from Dr. Petrolak in the neoadjuvant enfortumab vedotin cohort 8 of the EV103, I think it's a small study, 20 patients. It is promising in terms of the pathologic complete response rate and downstaging, but definitely cannot influence practice. But I think it lends support to 3 ongoing phase 3 trials in the neoadjuvant setting. The Keynote B15 with Pembro EV in cisplatin eligible patients, the Keynote 905 in cisplatin eligible patients. And there's a third trial called Volga, which is evaluating enfortumab vedotin, durvalumab, tremelimumab. So interesting to see a triplet being evaluated. So I agree totally with you. Not practice changing, but they support further evaluation of this antibody drug conjugates in different settings.
Great. Petros, Dr. Sasse raised a question about the platinum eligibility criteria. In your practice, a practice question actually, which criteria do you recommend for your patients in terms of eligibility for platinum therapy?
That's a great question. So I will start by answering your question for cisplatin specifically, because I can comment also on the so-called platinum, cis and carbo ineligible. But for cisplatin, I think most of us use the Galsky criteria. And it's interesting because the Galsky criteria were developed back 2011 based on a survey that Matt Galsky from Mount Sinai sent in other colleagues. And the 5 criteria that came up as relevant from the investigators included performance status ECOG 2 or higher was not good for cisplatin, hearing loss grade 2 or higher, neuropathy grade 2 or higher, symptomatic heart failure, NYHA class 3 or higher, and kidney impairment. And for kidney impairment, the creatinine clearance cutoff was 60, so less than 60 was not good for cisplatin. So we use that criteria. However, in my practice, in the absence of a trial, if someone is a good candidate for cisplatin otherwise, I may give cisplatin even with a creatinine clearance 50 or higher, and I may sometimes, depending on the case, may split the cisplatin dose on day 1 and day 8, if, for example, I give Gemcis. So it depends on the case. Of course, there are some other, potential factors to take into account. If someone has very bad COPD on oxygen at home, right, cannot walk a lot, of course, this probably ECOG PS of 2. But, you take into account nutritional factors, someone who has, significant other medical comorbidities, very elderly patients, but age by itself is not a criterion. What I call chronologic age, a number is not a criterion, but it's a physiologic age, right? In the context of other medical conditions are relevant factors. And of course, nutritional factors, social factors, support, they need to be compliant, they have to be reliable to come to the cancer center, go to the emergency room, if there's any side effect. So all those factors are taken into account. And now we're working here at the University of Washington with Dr. Sutka and others to evaluate and develop some more objective tools to evaluate fitness and frailty and resilience of patients. So that more work to be done. But the short answer is we use cisplatin based criteria based on Galsky and all. For platinum, cis and carboplatin, that's a longer discussion, and it applies mainly to the metastatic disease first-line setting, because in the US we can use Atezo or Pembro for platinum, cis, and carbo unfit patients in the frontline setting regardless of PD-L1. And the question is how we define this cis and carbo unfit. And Dr. Gupta from Cleveland Clinic is leading an effort, and we're having a call next week to discuss this definition. And we need to have a consensus, right? For example, we had an abstract at ASCO 2019, GU ASCO actually, 2019 symposium. And the factors that were relevant to some of the investigators for platinum ineligibility, meaning cis and carbo not fit patients, including an ECOG PS of 3, peripheral neuropathy, I think it was grade 3 or higher. It was creatinine clearance below 30 and ECOG PS of 2 plus creatinine clearance below 60. But we're going to discuss more about this cis and carbo ineligibility criteria, more to come on that.
And Petros, do you really believe there are real difference between efficacy of carbo and cis for a patient with almost cisplatin eligible or with a marginal loss of kidney function? Do you believe that we need to force the patients to receive cisplatin, or we can manage the toxicities with carbo, for example?
Another great question. I will tell you as of today, I still believe in cisplatin more than carboplatin. I still believe cisplatin is a better drug for urothelial cancer. Why do I say that? Oh, it's a number of reasons. Number one, in metastatic disease, there have been many retrospective studies suggesting that patients do better with cisplatin or carboplatin. Now you can tell me, yes, retrospective studies have many selection biases and confounding factors, like the more fit patients do better anyway, right? And may have done better, even if they got good carbo. There were two studies looking at that, looking at patients who were fit for cisplatin based on the investigator, but they got carboplatin and they had inferior outcomes compared to those who got cisplatin. Again, retrospective studies. We don't have any solid high-level evidence of prospective trial to compare. That's a caveat. But if you look at all the data together, they point to the same direction. Cisplatin is a better drug. And also in this is metastatic disease, but also in the neoadjuvant setting, we have level 1 evidence of cisplatin-based neoadjuvant chemotherapy, right, from the EORTC-MRC trial in Europe, from the SWOG 8710 in US, and the meta-analysis. But we do not have, and I have been part of that trial, we do not have enough data of evidence of benefit with carboplatin in the neoadjuvant setting. So putting all the data together, I would say that I still try to give cisplatin as much as I can. And if I do not feel comfortable for cisplatin, especially in metastatic disease, I use carboplatin as my second, like, plan B. And now with maintenance avelumab data, we know that patients benefit from avelumab regardless of cis or carbo. But I try to start with cis if I feel comfortable giving it.
Great, excellent discussion. We are now moving to the next two abstracts we will discuss later. Próximo slide, esses conflitos de interesse. Bom, então nós vamos discutir dois abstracts que eu considero o primeiro mais relevante do que o segundo em termos de mudança de clínica na prática clínica, ou principalmente por tomada de decisão. E nós vamos discutir um estudo que até então não tinha sido feito, que é um estudo multi-institucional, com várias universidades importantes dos Estados Unidos e Canadá, que, embora retrospectivo, essa análise ela tenta responder uma resposta que ainda não está definida, que é o papel da trimodalidade em comparação à cistectomia. Nós sabemos claramente que a cistectomia radical tem sido o gold standard para esse cenário de doença músculo-invasiva, né? E nós sabemos que existe uma população bastante comum na prática clínica, principalmente aqueles que declinam de cistectomia, que incluem basicamente uma RTU máxima seguida de rádio com quimioterapia sensibilizante. E claro que para esse cenário de pacientes, onde a gente já tem séries retrospectivas, a maior delas é o banco de dados do Mass General Hospital, que mostram que existem pacientes candidatos realmente, que são os melhores candidatos para essa abordagem, que são aqueles pacientes com tumores únicos, maioria deles T2 ou T3, que não têm ou têm uma mínima hidronefrose, que não tem um componente in situ associado, ou seja, uma doença heterogênea em toda a bexiga, que tem um tumor único menor que 7 centímetros, que consigam fazer uma RTU máxima e que tenham uma boa capacidade vesical. Essa análise retrospectiva contou com mais de 700 pacientes, todos eles T2 a T4 com N0, e eles foram então randomizados, né, para um grupo maior para a cistectomia radical versus então a trimodalidade. Então essas são as características já descritas e as metodologias estatísticas desse estudo. Foi avaliado então a regressão logística, sobrevida global com o modelo de Cox ajustado, e o objetivo primário foi sobrevida livre de metástases, que a gente já plota aqui nesse slide e já mostra uma semelhança em termos de sobrevida ou probabilidade de sobrevida a 5 anos para a trimodalidade, onde 78% dos pacientes estavam livres de doença, em comparação a 73%, e essa diferença não foi estatisticamente significativa. Da mesma forma, em termos de sobrevida livre de falha, os dados são bastante semelhantes, sem diferença estatística, e quando a gente avalia sobrevida global, há uma eventual superioridade da trimodalidade de 78% versus 66%, e esse P atingiu uma significância estatística. Ou seja, isso aqui mais ou menos é um conceito que a gente já eventualmente já tinha num cenário de tomada de decisão difícil, porque, de fato, muitos pacientes, na hora que recebem um diagnóstico de uma doença músculo-invasiva, a cistectomia radical é temida por muitos, e mesmo aqueles que são candidatos à quimioterapia neoadjuvante, quando são levados à cirurgia, muitos deles receiam e declinam desse tratamento. Então, como conclusão desse estudo, até o momento, essa é a melhor evidência, embora retrospectiva, na ausência de um estudo clínico randomizado, de favorecer, né, ou pelo menos colocar na discussão a trimodalidade para essa população de pacientes. Eu coloquei aqui, para facilitar essa discussão, alguns pontos que eu acho que vale a pena. A questão da seleção do paciente, se é o novo standard of care, possivelmente não, mas isso deve ser levado em consideração. Se esse tratamento deve ser realizado apenas em centros oncológicos de experiência, a necessidade de um follow-up rigoroso, qual o papel que a gente teria, ou de benefício algum, para quimio neoadjuvância seguida de trimodalidade, a gente não tem esse dado ainda, né? E exatamente essa é uma pergunta que eu vou fazer até para o André na sequência, se estudos como esse, análises retrospectivas bem feitas e do ponto de vista metodológico bem adequadas, poderiam eventualmente trocar, né, por estudos clínicos randomizados. Então, acho que esse é um ponto, tá, de discussão que a gente vai ter logo a seguir. E o segundo estudo, esse é um estudo menor, ainda uma prova de conceito, não um estudo que muda a prática, mas é o estudo Atlantis, que avalia o papel da manutenção do rucaparib, um inibidor da PARP, num cenário de seleção de pacientes. Então, aqui havia uma seleção de pacientes que tinham alteração de gene de reparo de DNA, lembrando que em câncer de bexiga essa alteração pode estar presente em até 25% dos pacientes, e é interessante porque há dados, né, não só em bexiga, que essa população de pacientes se beneficia de quimioterapia baseada em platina, e esse pequeno estudo, cerca de 20 pacientes só por cada braço, recebeu rucaparib versus placebo após quimioterapia baseada em cisplatina. O objetivo primário foi sobrevida livre de progressão, e o que esse estudo, na verdade, embora mostre numericamente mais do que o dobro de PFS favorecendo o rucaparib, não há uma diferença estatisticamente significativa, talvez até pelo baixo número de pacientes desse estudo fase 2 randomizado. O hazard ratio, vocês percebam, 0,53, bastante interessante, mas, de novo, é um estudo que só mostra um conceito e que talvez valha a pena, de fato, ser testado numa coorte fase 3 prospectiva. Em termos de efeitos colaterais, nada a declarar, isso basicamente está dentro daquilo que a gente espera com drogas como olaparib, rucaparib, niraparib, com fadiga, náusea, rash e anorexia como os efeitos mais comuns. E apenas uma comparação indireta, menos para provocar essa discussão, né? Esse estudo começou, esse fase 2 randomizado, na época que já estava em aprovação o evolumab, né? Claramente essa é a nossa conduta padrão hoje para os pacientes, e fica aqui a grande questão, André, se a gente deve testar agora esses pacientes, se está cedo ainda para a gente já conhecer esses pacientes que têm alteração de gene de reparo, e qual que seria o próximo passo. Então eu coloquei aqui algumas discussões para que possa então fomentar, né, tudo que a gente colocou. Então, once again, Dr. Petros, I think we can start with a trimodality trial, and I'd like to know your opinion about those data.
Thank you so much. Great presentation and very good point. So, number one, I think we probably will never be able to conduct a phase 3 trial. That was your last question. Between trimodality therapy and radical cystectomy and lymph node dissection in localized muscle-invasive bladder cancer. This trial was designed but stopped because it was never accrued. There were deviations and there was significant referral bias, as I say, patients who were not fit for surgery to go for radiation. So I don't think we'll probably ever have that trial. And the field is moving forward with, immunotherapy combinations, antibody drug conjugate combinations. So I think that we're probably going to rely on studies like this and other retrospective studies to help inform our decision-making with the patient. We cannot fully replace a randomized clinical trial because you cannot get rid of all the confounding factors and selection bias in a retrospective study. Even if you adjust, and I think Alex Slota and his colleagues did a great job, try to adjust all the confounders. It's just almost impossible, right, to avoid this inherent confounding and selection bias. Having said that, I think this study, with all the limitations of a retrospective study, I think gives you some confidence more than before to keep thinking about all the options. And at the University of Washington, we have a multi-specialty bladder cancer clinic. Every Tuesday morning, we see 4 new patients in the morning. And we look at the CAT scans, the images, the pathology slides, the labs, along with the pathologists and radiologists. And we have radiation oncology, medical oncology, and urology in the same room. And we discussed, and in about, I would say, 10 to 20% of patients, probably around 20%, we may offer bladder preservation in well-selected patients. So the answer here is good patient selection based on the criteria that you mentioned in the slide and Alex and his colleagues put in their study. So I think that study that we saw, again, cannot replace an randomized trial, but gives you some support to at least think about all the options and, again, offer it to the appropriate well-selected patients based on the criteria that you showed, and can not only to those who are not fit for surgery. I think we should broaden our criteria in patients who fit those criteria, and bladder preservation could be offered in those well-selected patients.
Great. I think that radical cystectomy is a huge surgery, causes a strong modification in quality of life of patients, and I have some sure that many patients would refuse if they were confident enough to make that decision to not operate and to go through radiotherapy and chemotherapy and preservation of bladder. So even if we think that it's not a true standard of care now, maybe with this data we can feel more confident to offer to all patients now. How can we deal with this information to the patient in the clinical practice?
That's a great question, and I think your point is important that radical cystectomy is life-changing. Having said that, I think most patients should and will receive radical cystectomy and pelvic lymph node dissection, ideally after neoadjuvant cisplatin-based chemotherapy, if they're fit for cisplatin. I think it's a matter of discussion with the patient and very careful review of the criteria, as you pointed out. Smaller solitary tumors away from the trigon, not causing significant hydronephrosis, or at least no bilateral hydronephrosis, as you showed in the slide. Not extensive or diffuse carcinoma in situ. Very good bladder cancer function and capacity. I would say the question is variant histology, and variant histology makes you nervous sometimes for radiation, but we don't have good data about variant histology. I would say all those factors, and patient preference should be taken into account. I think the bottom line is we should think about, the patient phenotype, who could be a candidate. And if the patient is a good candidate for trimodality therapy, we should discuss in a balanced way both surgery and trimodality therapy, because in some places, trimodality therapy is not even discussed, in those fit patients. For TMT. So I think this study maybe will increase the proportion of providers who actually discuss as an option with the patient and put it in a balanced, discussion. There are some other patients who do not meet that criteria and they're fit for surgery and they will go for surgery. And most patients go for surgery, no doubt. But I think, again, there's in our practice about 20% of patients, 1 out of 5, who meet the criteria, and at least we should have a balanced discussion about both options in those patients and help them decide, and have, maybe an ostomy nurse with us in the clinic. Talk about ostomy, right, after surgery. Talk about the potential side effects of each approach. And also, that in the trimodality therapy, there's a chance that people may need cystectomy down the road. Maybe a proportion of 20-25% or so, more or less, they may need salvage cystectomy, and that should be discussed with the patient. And technically, that may be more difficult after radiation, but it's feasible. It can be done. And also, of course, if someone has locally recurrent disease, the quality of life could be impaired if the bladder is in place and they develop crippling symptoms. But on the other side, many patients may be having very good bladder cancer-free survival with trimodality therapy. So again, I think it's the study, increases our horizon and makes us think that in properly selected patients, we should discuss both options in a balanced way and not only one option.
Great. And how about the patient population who received neoadjuvant chemo and then declined after 6 cycles, for example, of surgery, and then we move to trimodality, for example? What do you think? You can have better results with neoadjuvant plus conservative procedure?
That's a great question. So going back in time, I remember the EORTC MRC trial in Europe. They did neoadjuvant chemotherapy with MVC, and then the patients could go for radical cystectomy, lymph node dissection, or radiation as a definitive therapy. And that trial overall was positive for the benefit of neoadjuvant chemo. Having said that, I think that patients who get neoadjuvant chemo usually go for surgery. And in my mind, the route is either chemodality, maximum TURBT and concurrent chemoradiation, chemodality therapy in well-selected patients, or suspended basic chemotherapy neoadjuvantly followed by radical surgery. We do not have good data so far. We had 2 small studies that were negative in the past. At least one that was negative in the past, looking at neoadjuvant chemo with 2 cycles followed by TMT, chemodality therapy, and that study was negative, so no benefit with neoadjuvant chemo. However, this was probably not, I would say, very informative because many patients had toxicity with chemotherapy, died early, and I think we need a new study in the modern era to answer that question of neoadjuvant chemo, yes or no, before chemodality therapy. We don't have good data. In the absence of data in our center, we do not offer neoadjuvant chemo before chemodality therapy, but I know some others do, for example, in Canada, and we don't have good data to guide us. That's a different scenario. What you're asking is, you start with a goal to go for surgery, radical cystectomy, and you give neoadjuvant chemo, and the patient changes their mind, right, after chemotherapy. What do you do? And that's a tough one. So I talk to the patient along with the urologist, the ostomy nurse, and we also give them resources about the Bladder Cancer Advocacy Network, BCAN, Beacon. This is a group of a patient advocacy group that actually can have support lines, and they can talk to patients in a survivor to patient manner. They have support groups and tell the patients how life is after cystectomy, so they can have more information to make an informed decision. And we also may connect them with other patients and say, hey, talk to this patient, he had cystectomy or she had cystectomy, see how life is afterwards. Some people, they agree to do it after that. If the patient still declines cystectomy despite all the efforts, then the discussion is, if there is no metastasis, you have localized disease with curative intent, can you do radiation? And that we have done that before. If they decline surgery after chemotherapy, we have done radiation. And if the patient is fit enough, we add some radiosensitizing chemo in that setting. So we do chemoradiation, in that context for patients who decline surgery after neoadjuvant chemo. And we have seen some variable results. The last comment I have is there have been 3 interesting studies looking at patients who got neoadjuvant chemo, and then based on the presence of clinical complete response and maybe mutations in DNA repair genes, they may potentially be either observed or do intravesical therapy for non-muscle invasive disease or cystectomy or chemodality therapy. And this study was a retained study at Fox Chase by Dr. Plimak and Dr. Gainsman and others. And there was another study by Dr. Galsky with Gemcis Nivo. The bottom line is, right now, the data look promising for this approach, but are not ready yet. Meaning, if someone gets neoadjuvant chemo, ideally, the goal is to get them to surgery. And we try to, have this dialogue with the patient to continue the initial plan. But I think the future, 5-10 years from now, we're going to have more trial data to evaluate whether it's safe or not to save the bladder after neoadjuvant chemo for those with clinical complete response and relevant mutations. We're getting there, hopefully in the future, but we're not there yet. So for now, we usually follow the standard of care. And those who decline a radical cystectomy, we may default to radiation, maybe with some radiosensitizing chemotherapy in that case, and do follow up.
Okay. Before I move to Atlantis, a quick answer. For those patients who receive 3-modality therapy, any role for adjuvant nivo?
Great question. Very good. I knew that you would ask that. The short answer is no. We don't have this data yet. It's interesting question. I think it merits its own trial. However, I want to point out there are actually 2 important phase 3 trials with bladder preservation. One is called SWOG NRG 1806. The other is KEYNOTE 992. These trials are taking patients with maximum TURBT. They get concurrent chemoradiation with or without atezolizumab, and there's some maintenance atezolizumab afterwards, 9 doses total for the SWOG NRG 1806 trial, and pembrolizumab is the addition to chemo-RT for the Keynote 992 trial. So those 2 trials will have some component of checkpoint inhibition that continues for a few doses, I think about 6 months or so after you finish chemoradiation. So these trials will give you some answers there. But until we have those trials resulted, the short answer is for now, if someone finishes chemo-RT, I'm not using yet nivolumab because it was a different setting after surgery. So I'm not using it as of now.
Okay, our last question. What's your thoughts about the PARP inhibitors in urothelial cancer? What's the future role of this?
That's a very dear topic for me. I will try to keep my answer short because it's a very, very important topic. So the short answer is the data have not been promised, have not been convincing so far. If you look at all the trials that we have done, there is a signal though. Well, we have to find the signal and who are the patients? What is the biomarker to select our patients for PARP inhibitors, right? So let's start with, if you think about the existing trials, in the neoadjuvant setting, we had the neoadjuvant durvalumab olaparib, the neodurparib trial. This was presented, I think, 1 or 2 years ago at ASCO GU. Pathological complete response rate was promising, but it was single-arm study. Again, back to your question, we don't know the contribution of PARP inhibitor to durvalumab neoadjuvantly. It was experimental, but single-arm. And then metastatic disease, we have the Bayou trial by Jonathan Rosenberg at ASCO GU, negative study, but again, there was some question about signal in DNA repair gene mutation patients. And then you have the Atlantis that you mentioned, interesting, that showed some notable difference in median PFS in those with DNA repair gene mutations, but small sample size and not well powered. And then you have, in platinum refractory disease, the Atlas trial that I had the chance to co-lead with Dr. Chowdhury and others, and we published that in BMC Cancer, and it was a negative trial, about 97 patients, platinum refractory. We saw no responses, but we did not select our patients, right? And then you have also the Bayou trial that we did with Tom Powles and others, that was durvalumab olaparib, about 36% response rate in platinum refractory in selected patients based on DDR mutations. But again, you don't know durva alone or the combinations played a role. And then you had the negative maintenance trial with the MEET-URO with niraparib in the maintenance setting, not selected, I think, patients, it was negative. So bottom line, the PARP inhibition story so far has been underwhelming. We would have expected more. However, and there's no role right now in practice. However, I still believe there is a proportion of patients, small, who can benefit. Who are those patients? Who are working on it. So maybe patients with germline mutations in DNA repair genes, or somatic mutations with loss of heterozygosity in the other allele, and HR deficiency, homologous recombination deficiency. So my take home is no practice changing for now. We have to work further on the right biomarker, select the patients, and maybe we have to go before patients become platinum refractory, maybe in the front line or in the maintenance setting, maybe the way to go, because maybe there is some resistance overlap between platinum and PARP inhibition, and that's a hypothesis, but we still have work to do there.
Okay, great. Unfortunately, we finished our time. We'd like to thank you again, the great discussions. It was a pleasure, and hope you see you soon.
Preferably
Thank you so much.
Here in Brazil.
Yes.
Obrigado. I'm looking forward to seeing you in Brazil. Thanks for having me. And I get very enthusiastic about urothelial cancer. So I want to share my thoughts. And some of the answers were long, but I hopefully covered all your great questions.
Okay.
Thank you.
Thank you.
Thank you.